Hello, everyone. Welcome to another webinar from the AMA Steps Forward Innovation Academy. Today, we'll be discussing the AMA Debunking Medical Practice Regulatory Myths Learning Series. And over the next 45 minutes, we'll discuss how to help clinical team members, organizational leaders, and medical practice operations leaders better understand how unnecessary and overinterpreted regulations impair efficiency. Please note that this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult with a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. And before we get started with our speakers, we'd like to briefly go over the dashboard you see on your screen. You can resize or minimize any of these widgets as you see fit by clicking and dragging them around the screen. Let me show you folks around. So here, the screen in the middle is your media player, where you'll be able to view the presentation. If you're viewing on demand, you will be able to pause and skip forward and back to review specific moments of the presentation at your leisure. On the left, you'll be able to learn more about our subject matter experts and also submit questions for us to answer after the presentation if you are attending live. On the right, you can access resources key to this presentation's learning goals, and you will also notice a link to claim CME credit for your attendance today. There is a brief survey available for you to complete at any time, and we take your feedback seriously as we continue to improve our program for you, so please fill out by the time our webinar ends. And finally, you can follow this link to learn more about our past and future webinars, which are available for you to access at your convenience. Joining us today is Dr. Kevin Hopkins, Physician Director, Health Systems Engagement here at the AMA, and with him is Robin Hoffman, Senior Compliance Manager at Berry, Dunn, McNeil, and Parker. Dr. Hopkins, the floor is yours.
All right. Thank you, Alec. You can hear me okay?
Yes, we can hear you.
All right, great. So it's a pleasure to be joined by my friend and colleague, Robin Hoffman. And so we will do our best today to get through the content that we have planned and save time at the end for some questions and hopefully deliver some answers to the questions that are burning at the top of your mind. Some of the content, a lot of the content we'll be covering today is directly from the Reducing Regulatory Burden Playbook from the AMA Steps Forward series, and this was published just under a year ago, last June. There's also content that we'll be sharing from an article that Robin and I recently published, along with our partner and colleague, Lindsay Carlasari, that published in the Compliance Today magazine, which is a magazine of the Healthcare Compliance Association. The link and the QR code that are included here are open access so that you can read that article if you would like, and feel free to share it. But we address the opportunity to advance shared accountability to help reduce regulatory burden and promote well-being, specifically in healthcare, and how we navigate the dynamic work between healthcare professionals, particularly physicians, and other healthcare administrative leaders like regulatory compliance folks. So when you think about regulatory compliance and physician leaders separately, it's easy to see how we might have very different goals. Certainly the primary purpose of a compliance office is to manage risk and to manage that for the organization's benefit, while the primary purpose of physicians and our teams is to preserve and improve our patients' health for the overall benefit of the organization. But if we can step back and take a look at the larger picture from a holistic point of view, compliance and clinical teams really have much more in common than not. We have a lot of shared priorities, and they likely include things like promoting ethical conduct, patient safety, high quality care, minimizing risk, maintaining accreditation, sustaining the organization's mission, financial viability, and also good organizational standing in the community. So when we recognize those mutual values, it can help us to identify areas for improvement and opportunities for better alignment. So here are some of those things that I mentioned. We want to assure the delivery of safe, high quality care and avoid conflict of interest, demonstrate integrity in our actions, safeguard patient privacy, and serve as role models for ethical behavior. And when we think about all of these things, if we can do them successfully and work together, physician leaders and compliance officers can help to achieve the quadruple aim. We can build a culture of integrity and shared accountability in which patient safety, compliance, and physician well-being all benefit. You're probably all familiar with the quadruple aim, and now that's been expanded to include the quintuple aim, but the quadruple aim includes improved patient care at lower cost with better outcomes while also prioritizing clinician well-being. Some of this has to do with the time that we have available for delivering care. There are many physicians today that just feel like it's not possible to provide the level of care that we want and that our patients deserve and expect. And the reason we feel like it's impossible is, in part, it is. This is a time study that was done in 2022 to measure the amount of time that it would take to provide primary care for a panel of 2,500 patients. If we just address chronic disease management, over 7 hours a day. Preventative care, 14 hours a day. Acute care, over 2 hours a day. And documentation accounts for a full 3 hours per day. You sum that up and it's 26 hours a day, certainly more than we can possibly do or anybody could be expected. This leads to increasing levels of exhaustion, fatigue, and even burnout among healthcare professionals, particularly physicians, but really at all levels of our healthcare systems. And when you think about burnout, it has many costs. Certainly patient care suffers, quality outcomes decrease, cost of care increases, and part of that cost of care is tied up in the direct effects of burnout. So this is a cost that was published in 2019. That's an estimate that was developed by researchers from Stanford, Mayo Clinic, and the AMA. And they developed a mathematical model using published research findings and industry reports to estimate burnout's associated costs related to physician turnover and reduced clinical hours. And what they found is that approximately $4.6 billion a year are spent directly related to physician burnout. And this only accounts for turnover and reduced clinical effort, the replacement and lost productivity. It doesn't account for additional costs of higher malpractice claims, higher rates of medical errors, and decreased patient satisfaction, all of which we know are directly related to physician burnout. And so the AMA has developed tools that can help. Part of our goal and our responsibility and mission is to remove barriers from providing excellent patient care. And so we've developed tools like the AMA Steps Forward series, which hopefully you've heard of, but that I introduced a little bit earlier. Also our organizational biopsy, where organizations can survey their employees, particularly their physicians, about rates of burnout and professional satisfaction. We also sponsored the AMA Joy in Medicine Health System Recognition Program that recognize health systems and practices that are prioritizing physician well-being. Also a part of our suite of services is this series called Debunking Regulatory Myths. It aims to help organizations reduce administrative burden and increase physician satisfaction through clarification of often misunderstood or misinterpreted regulations. The series has already explored almost 30 topics, and those topics are explored, researched, and have found to be true regulatory myths. They're then debunked in a brief, easy to understand one-page summary document. It includes resources and references to help reduce regulatory guesswork and associated administrative burden so that physicians and our teams can really focus on what matters most, providing great care to our patients. Our goal is not to eliminate regulation and oversight, but rather to sensibly reduce the unnecessary burden that is exerted on clinicians and our teams. Part of the issue when it comes to regulatory burden is having a clear understanding about who makes the rules. When you look at the organizations and the regulatory agencies that oversee healthcare, it's pretty diverse. The stakeholders include federal regulatory agencies, state boards, accreditation agencies. These govern physicians and healthcare practices in many ways, including making rules that we need to abide by. But it also includes things like payers, EHR vendors, and even a physician's own healthcare system. Additionally, there are associations, societies, and advocacy groups that make statements and non-binding recommendations that are sometimes misinterpreted or overinterpreted as quote unquote regulatory requirements. As a result, physicians today feel the tremendous oversight and regulatory burden from both internal and external sources. Unfortunately, much of the regulatory frustration that we experience is due to local practice and institutional policies and procedures that are designed to help keep clinicians, our practices, and our hospital systems compliant with the organization's interpretation of regulatory requirements. Each organization has to understand how unnecessary regulations and potential overinterpretation of those regulations can impair our efficiency. And everybody has a different tolerance risk, and so that all goes into the calculation. But sometimes we put handcuffs on ourselves. Regulatory burden and regulatory requirements necessarily slow us down so that we can provide safe patient care and prioritize safety. And yet sometimes they slow us down to the point that they impede our optimal efficiency and actually can create unintended negative consequences, even patient dangers. So when you think about the categories of regulatory burdens that we have in healthcare, that can include things like technical burdens, clicks and required attestations in the EHR, certainly documentation burden, billing and coding specific rules, workflow, things that are rolled out across our organization or practice in the name of efficiency. There's also scope of practice limitations around who can do what, and often confusion there. And then patient quality and safety, which of course nobody would argue with. But all of these taken collectively can exert a significant burden on our healthcare system and the people who provide the care. So what's the difference across some of these? There are actual regulatory requirements, things that are mandatory for us to comply with and have a legal obligation from usually a federal or state agency. But also when we think about regulatory compliance, we kind of lump in organizational policies. These are not legal requirements, but they are institutional rules that are usually developed to ensure adherence and compliance with a determined legal obligation. Certainly there are other policies that aren't specifically to adhere to legal obligation, but for the purpose of our conversation today, that's kind of what I'm thinking about when I say organizational policies. We also have standard operating procedures, how we do what in our organization. There's standard workflows, what is done, how it's done, by whom it's done, where and when it gets done. And then there's recommendations or best practices. These are certainly non-binding guidance or suggestions. And yet, taken collectively, sometimes we overinterpret these and put them all in the bucket of regulatory requirements or regulatory compliance issues. When you think about who all's involved, I mentioned some of the key players earlier, but with true regulatory requirements, we're talking about generally government entities. Certainly within our organizations, our policies and procedures, that includes the C-suite leaders, clinical and clerical leaders, executive admin, and hospital boards. Standard operating procedures might be developed by our nursing leaders, clerical and clinical folks. They might even be an outside consultant or risk management and revenue cycle. Same things for standard workflow, and that might also include continuous improvement, our IT partners, and our EHR vendors. And then recommendations and best practices are usually made, as I mentioned earlier, by professional societies and advocacy groups, but they all come into play. And when we think about regulatory burden and reducing it, it's important for us to think, what is in our control? It's very easy for us to say, well, so much of this is outside of our control because it's dictated by government entities. And yet, that's not entirely true. This is a quote that I like from Don Berwick. He's President Emeritus and Senior Fellow at the Institute for Healthcare Improvement. You know it as IHI. Also a former administrator at the Centers for Medicare and Medicaid Services. And he says in a report that IHI released, the majority, 78% of obstructive and wasteful rules identified by patients and staff were fully within the administrative control of healthcare executives and managers to change. So while specific policy requirements may not be completely under your direct control or even your office's control, asking questions about them, inquiring about them really is under your control. When we think about the unnecessary and unintended negative consequences or risk associated with overinterpretation of regulatory requirements, there are many. And I won't read this slide to you, but it includes increased workload, particularly administrative burden and documentation, cognitive overload, organizational trust issues and care team dysfunction. And it can also ultimately impede patient care by affecting the patient-physician relationship and reducing capacity to care for patients and affecting healthcare costs overall. So many of us have probably said or have heard it's a regulatory requirement. When care teams or practice leaders ask why a process has to be done or has to be done in a certain way and they get that explanation, it's a regulatory requirement. Our tendency is to sort of just give in and accept that explanation. But asking clarifying questions when there's uncertainty should always be encouraged. So, in my opinion, the response to this explanation, it's a regulatory requirement, should always be followed by some variation of this essential phrase. Can you please show me that regulation and where it comes from? Asking questions in a respectful, honoring way can show our level of engagement. It also helps to provide clarity. Understanding why we have to do something and why we have to do it in a certain way helps us with increasing levels of compliance and adherence. Sometimes we find out that what we're being told is a regulatory requirement isn't really a regulatory requirement after all. Sometimes it's something that's been put in place with the best of intentions by organizational or health system leaders in order to keep us compliant with real regulatory requirements. Here's a list of follow-up questions that you can ask when you're told that something is a regulatory requirement. And I think it's important for us to have, particularly our physician leaders, to have a real genuine attitude of humility when we ask these questions, because I could ask these same questions in a snarky way or a doubting way, but that's not gonna increase the opportunity for us to collaborate and reduce regulatory burden overall. So one of the things that we can do when we reduce regulatory burden is we can help stop unnecessary low value work. One of the things we're not so good at in health systems is stopping things. We often sort of just add on to a plate that's already full to overflowing. And taking a look around at what we can stop doing that maybe no longer has the same value that it once did is a good thing that we should do with regularity. Often we recognize things like system errors or things that are done incorrectly, that people make mistakes. And when bad things happen, it's usually either a people person or a process problem. If people see a better way or see that the way that we've laid out for them to complete something isn't the best way or isn't the most efficient way, they'll adopt workarounds, and that's where errors tend to happen. So when we see errors happening, the first thing we shouldn't do is point the finger at the person. We should take a look at the process. Keys to success when it comes to reducing regulatory burden include developing leadership support and buy-in, making sure that we have time in our day, the time and space to dedicate to this, engaging the stakeholders, like I said, making sure that we have an organizational culture of wellness and continuous improvement, effective communication and gaining willing partners and access to data, and then maintaining momentum once we get started. I won't go through this, but this is a chart of key stakeholders from the playbook that I mentioned earlier about who to engage regarding specific regulatory burdens when it comes to reducing those. I want to share with you a few success stories and then pass it over to my colleague, Robin, because I think it's important for you to know some specifics. What we're going to spend our time talking about today is high-level process, how to question and how to potentially reduce regulatory burden. But let me show you some real-world examples. This is a quote from me. "The sound of keyboard tapping and mouse clicking has become the sound of joy, leaving physicians through their fingertips." So I'm a physician leader at Cleveland Clinic. I've been at Cleveland Clinic for 20 years. And one of the things that we did for a long time was two-factor authentication or password revalidation for positive identification for filing orders for all prescriptions, even non-controlled medications. We were told it was a state board of pharmacy regulation. And for a long time, it was, until it wasn't. In fall 2022, we looked into this issue again. And it turned out that the long-standing requirement affecting the way we sign prescription orders had changed sometime in 2021, but nobody who was directly affected by it seemed to know about it. So this was something we were able to change. And our physicians no longer have to re-enter their password or do a badge tap or biometrics in order to sign non-controlled medication orders. Just in our system, this affected over 11 million orders per year. And when you take the time that it took for our physicians to sign those orders, it adds up to an estimated cost of $2 million per year. So it's no small deal. But if we hadn't asked the question, can you please show me that regulatory requirement and where it comes from, we'd still be doing all that additional clicking and tapping and losing more joy each time. A couple other quick success stories. University of Nebraska Medical Center made the change to suppress delivery of patient medical advice requests where the patient was just responding and saying some form of thank you. And by doing this, an estimated 50,000 messages per year were stopped from coming into care teams' EHR inboxes. This is a quote from Dr. Marie Brown about standardization of long-term prescription renewals for the maximum allowed quantity. In some states, it's 12 months. In others, it's 15, 18 months, or even 24. And she said with saving an hour per day by doing that, we had the time in our practice to identify patients who missed appointments and reach out to provide health coaching. So stop doing some things that are low value or less value so that we can focus on things that are of higher value. Robin, I'm going to hand it over to you to talk about the Compliance Committee and our work in healthcare organizations from a compliance professional perspective.
Thank you so much, Kevin. And again, I am really grateful to meet with you today and to have this opportunity. I really enjoyed working with you as we developed the article for Compliance Today, which is the professional publication for compliance professionals throughout the world, if you will. So this document, which is on your screen right now, is from the Office of the Inspector General at the Department of Health and Human Services. And this document was released in November of 2023. It is the General Compliance Program Guidance, and this is a document which is a voluntary one where the OIG is setting forth voluntary compliance recommendations to healthcare organizations. And what I think is really great about this document is that it really has the opportunity, if you will, to share with organizations which may be small in size or large in size, because obviously the size of an organization frequently impacts whether there even is a compliance officer in an organization. So this OIG guidance document, again, is one that really, I think, has some really tangible, useful recommendations, particularly for smaller organizations. And one of the things that they talk about is the importance of the compliance committee. And the compliance committee, as Kevin and I have talked about this over the past several months, that's a really, I think, foundational, important committee for the organization, for the healthcare setting, because it's critically important to have clinical leadership actively involved in the compliance committee. Why? Because the compliance committee really develops the annual compliance work plan. The compliance committee also has responsibilities around establishing training requirements around things like compliance and HIPAA privacy. So it's really critical to have clinical leadership as active members of the compliance committee. And the OIG recommends that the committee meet at least quarterly. Obviously, if something of an important issue were to arise, the committee would be convened again to deal with that issue. But it's really important that it represent clinical compliance as well as other leaders within the organization. So it brings together a lot of key folks that are really, if you will, impacting what happens within the organization. And they give a great description. I've already mentioned about the committee helps to formulate the compliance work plan. It establishes training requirements, and it also looks at policies and procedures and looks at whether the compliance plan is really, is it really an effective one or not? So again, I would strongly urge clinical leaders, if you're not being invited to the compliance committee, again, Kevin, you said so nicely, it's like, that's one of those questions where you go, call up, say, hey, I understand there's a compliance committee. I'd really like to talk with you about how I could offer, my inputs into that really important organizational committee. And I think one of the things is, again, I had been a compliance professional in a federally qualified health center, which was growing. So it was an organization that over the course of time substantially grew its behavioral health services. It substantially grew its dental services. This was a health center, for instance, that had nurse midwifery staff who actually conducted deliveries at a local hospital. We added a lot of programs such as gerontology. So I think it's really critical, again, speaking to the dynamic nature of healthcare. Also, the compliance committee needs to be dynamic in its nature as well. So you want to make sure that whatever the size or type of the healthcare organization, that the clinicians who were involved in services have representation on the committee. And again, I think I always like to think of, because by training originally, I'm a community health clinical nurse specialist. So I always think about quality improvement methodologies, plan, do, study, act types of initiatives. And I think, PDSAs are used so frequently and so critically in the clinical floor, I'll say, to speak. But I think really the compliance team really needs to be thinking in terms of plan, do, study, act. And I think, again, PDSA models are great ways for clinical leaders and compliance leaders to really work together. And I've so enjoyed learning from Kevin over the past several months about all of the myth busting that is taking place. And I think that if you're looking at rapid cycle change, you really want to invoke, if you will, a PDSA method. So I think that there are some great ways that as an organization is changing to make its work environment more, if you will, how should I say it? Let me think about this. How to make it so that we're not inducing burnout, if you will, in clinicians. We want to make sure that, particularly that young clinicians that are coming into healthcare are not wanting to leave the profession within a brief amount of time. So I think PDSAs are a great way for compliance and clinical leaders to really look at putting in some new workflows, and PDSAs are a great way to really see whether that cycle of change is a successful one or not. And we've listed some of those on the slide here. We've also talked about some of that in the article that we produced for Compliance Today. And I think huddles, I think of huddles as being, again, very familiar with huddles from clinical environments where it's a nice rapid way to really look at what's happening. I think that there are ways that you could consider piloting huddles that involve the compliance as well as the clinical teams in an organization. So I think that, again, huddles, I think are something I'd say pilot it, see how it works. If it's causing more work, then I wouldn't do it. But if it is helpful, then I think it's really something to consider adopting. And I think, what's really important is one of the things that we have on the slide is what is referred to as emerging CUS, meaning I am concerned, I am uncomfortable, and this is a safety issue. So you want that kind of information bubbling up from the clinical environments as quickly as something is identified, so that, again, patient safety is promoted, and if there are workflows that need to be remediated, that can be done promptly. I think also a huddle is another way to share information with clinical teams, so that, say that there's been an external audit or a regulatory site visit. For instance, the state in which I was a compliance professional, we had visits from the State Department of Health, which were unannounced, and those happened every 2 years. So getting the findings from anything like that, critically important to share those results, which could be really stellar, wonderful results and feedback from a regulator, or it could be where there are recommendations and need for remediation. I think, again, that's a great huddle topic as well. And I think, what I always say to compliance professionals is that you need to be approachable, accessible, and responsive. And in the FQHC actually had the opportunity to meet with each orientation cohort. And this was an organization where clinicians as well as non-clinicians all came in on the same day and really started their orientation and then moved into the orientation that was specific to their profession or to their functional area. But I always said to people, you know, you're getting so much information. I think of like Monty Python, the old Monty Python thing where it's like you see the cranium kind of pop up and you see all these things flowing into the cranium. It's like that's what orienting in any new organization is like, and it's only more like that these days. So I always said, here's how you reach me. I would actually send an email, a personal email to each person. I would give them information about how to contact me. I think one of the things that I always tried to let people know is that, you know, there are questions that you're going to have in the course of your workday. So please, you know, all of what we're talking about here in terms of regulatory myths and so forth, don't feel like, you know, if you're a new APRN, or if you're a new physician coming into a practice, don't feel like you have to take that on yourself and try to research that all yourself. There are ways that you can bring that forward in the organization to go, like, Robin, I really don't understand this. Can you help me? And that, I would say, like, that's my job. My job is to assist you so that we can look at this together and get answers. The other thing is that I would always say, you know, just pick up the phone and call me. Or, you know, again, I was in an environment where if people wanted to come into my office, I had an open door policy that I was always saying, I'd rather, you know, bring it forward now before you really start to get sort of stuck in a question. And also, I would say, please, if you're wanting to talk about something, be very cautious about email, because sometimes emails can really kind of just start to kind of blow up, if you will. So it's great to have that conversation first. I think, you know, old school, it's good to have a conversation with somebody, whether it's face-to-face or by telephone. And then always, I would say to any clinician, if you're getting correspondence from a regulator, particularly, or from a payer, bring that forward to compliance and go, you know, like, is this innocuous, or is this something that, you know, we really need to sit down and have a conversation about? So you really want to make sure that you're feeling comfortable. And look at this. I use Edvard Munch's The Shriek or the Scream. I've seen the name both ways. You really want to make sure as a compliance professional that you are writing things which are, you know, brevity is the soul of wit. So to quote Shakespeare, you want to make sure that if you need to communicate in writing with clinicians, that you are keeping it very brief, that you are not loading the page down with a lot of federal or state citations. You want to keep things, because again, you're talking to busy people whose job is to care for patients. So try to keep compliance writings to a brief sort of thing. And then I'm a big believer in executive rounds. The health center that I was at, we started that process, and I think it's really an effective tool. So as a member of the executive management team, we would go out like every 2 months to a site and check in. And we would do that frequently one-on-one because we had so many sites. But it was a great way of bringing things back to executive leadership to identify there might have been issues within the site where staff had questions, or there might have been something going on in terms of, air quotes, the physical plant of, as we were doing a walkthrough, and people go, oh, well, it's always been like that. You want to let people know if you're identifying issues, you want to bring that forward, and you want to feel like your needs and your patients' needs are being met. So I think executive rounds are a great way to do that. I'm a big champion of that. And it's also a great way for clinicians and clinical support staff to share what they're proud of and to share a good vignette about something that happened with a patient. People need to hear those stories on both ends. The clinicians and the clinical team need to have the opportunity to bubble that forward and share that good news. It's very validating. And also, leadership needs to hear what are the issues that are being brought forward to clinicians by their patients. Really important. Always good to I like the line, shine the light on what's right. I think that that's a really good way to think about that. And then I know we're wanting to leave times for questions, but this is my term of being a regulations whisperer. And I've talked about, my willingness as a compliance professional to really answer questions that people have. And I think that, again, because compliance is not, if you will, conducting operations or legal work for the organization, that we're an independent entity, if you will, an independent body that can really work effectively with clinical leaders to help folks get the answers and understand where there may be, again, those kinds of issues like Joint Commission, who gets blamed for a lot in Joint Commission accredited organizations, where it's kind of one of those myths of the Joint Commission says so. A lot of times the Joint Commission does not say so. So I think that your compliance officer, as well as your quality improvement professional with clinical, that triad, if you will, is a very effective one for really, again, advancing patient safety, patient and clinician satisfaction, and hopefully helping to retain clinicians and reduce burnout and promote continuity of care. So Kevin, if you'd like to go back to some conversation about some of the key takeaways for today, I think that, this has been a great opportunity to talk about how our professions can work effectively together.
Yeah, absolutely. Thanks, Robin, for that. So yeah, what we wanted to convey today is that the relationship between physicians, particularly physician leaders and frontline physicians in a practice or healthcare organization with regulatory compliance professionals with organization does not need to be, and certainly shouldn't be, adversarial. We are on the same team and we want many of the same outcomes. We have many of the same goals and priorities. So our key takeaways from today are working with each other to identify shared values, explore opportunities for collaboration, and how we can best communicate. We want to assume positive intent by each other. Everybody's trying to do their job. Everybody's trying to do the best they can, but we may have different perspectives on things. We need to make sure we don't take things personally. Sometimes hard to do, but certainly important. We all want to be approachable and responsive and be a go-to resource for each other. We should look for opportunities to ask more questions than statements make. And then written messages, like Robin said, should be clear and succinct, less room left for interpretation. And then looking for chances to partner with quality improvement in designing rapid cycle PDSA projects to help us move in the right direction. So with that, we'll wrap up our content delivery, and we will be open to questions. And Alec, if you're able to moderate this for us. It looks like we don't have any questions coming in yet. But I will mention some questions that were actually submitted ahead of time. So it's very difficult for us to give advice and recommendations on specific regulatory compliance issues, other than things that are sort of blamed or attributed to federal regulatory agencies. So a lot of stuff is done at the state level: state boards of pharmacy, state board of nursing, state medical boards, state departments of health. So knowing where to look to find answers is very valuable, and leveraging our regulatory compliance professionals within our organizations as a go-to is really valuable. But I guess I would just encourage everybody to ask the question of, what regulatory agency does this come from? How are we in compliant? How are we not in compliant? What are other similar organizations like us doing in order to comply with this? Some of the questions that we got in advance were things like, is it okay to bill for preventative care and an E&M visit on the same day? Absolutely. In fact, we should be doing it. If we're not billing for the work that we're doing, then we're giving away free care, which is not responsible to our organizations or to the payers. But there is a way to do that appropriately. Things like choosing the right billing code with a 25 modifier, making sure the documentation is appropriate, and delineates the fact that a separate medical problem was addressed on the same day as preventative care. There's also questions about team documentation. with the change in E&M documentation regulations over the last several years, we're able to use not only staff documentation in things like the history of present illness in an ambulatory visit or in an inpatient visit, but even patient-entered documentation, as long as we've reviewed it and made sure that it's accurate. And so the old rules of who had to do what in the electronic health record in order to bill for a service don't apply any longer, because we bill in ambulatory now based on medical decision making alone or the time spent on the date of the encounter alone. We don't have to come up with however many bullets in each part of the documentation to hit those requirements. So I'd encourage folks to check out our Debunking Regulatory Myths series. Those are both topics that we address in those summary documents, and also the Steps Forward tools. But we're happy to take any other questions that folks may have today that we can hopefully answer.
I still don't see any coming through. For those of you who are attending, I've been highlighting the question box in the bottom left. So if you do have one, you can go ahead and drop it in there. We'll get to it. I'll go ahead and just do some of our kind of outro slides, just so you guys know about what we have upcoming while you're thinking of a question. And then we can address them once I wrap those up. So I want to highlight some of these items in our upcoming programming, but I do want to remind you folks, there is a survey widget on your console. You can take the time to answer the 2 questions there. It would mean so much to us. Your responses help guide our upcoming programming to deliver webinars you want to see, such as today's. You can join us for our next webinar, which will be on May 13th. It will be the next installment in our value-based care series with experts from Kaiser Permanente and Henry Ford Health, who will discuss opportunities and best practices for patient attribution, benchmarking, and risk adjustment within underlying payment methods. You can scan the QR code or click the link in your resources widget to register. And if you're looking for something a little more interactive that can come from our Steps Forward Innovation Academy, we would like to invite you all to join us in person for our next boot camp. You can learn best practices from top physician experts through interactive activities, thought sharing, tactical strategy breakdowns, and how-to examples. Our boot camps equip attendees with the time-saving tools and strategies needed to reform their organizations and enhance professional satisfaction. Registration for our upcoming boot camp on September 17th is open now, and if you have interest in attending or wish to learn more, you can scan the code on the slide right now. Dr. Hopkins is also a frequent presenter with us who has even more time to dive into this topic, should you be interested in joining. As a reminder, you can claim CME credit for attending today. That is also linked in the resources widget on the right-hand side, as well as slides and resources we mentioned throughout, such as past webinars and the article that our guest today co-authored. You can find them all there. If you have additional resources to support, if you're looking for additional resources to support your physicians and staff, you can visit the American Medical Association website or stepsforward.org. Now, I don't see any further questions have come in. Do either of you have some final parting thoughts for our guests today, for our audience today?
Go ahead, Robin.
Again, I really have so valued having the opportunity to engage with Dr. Hopkins and with Lindsay in developing the article for compliance today. It's been an honor, and I think that this is something where the compliance profession is very eager to partner with the AMA in any way possible around the debunking regulatory myths. I think that that is a wonderful, wonderful thing to do. Again, it's all to the good, if you will.
So if you leave today with 1 or 2 things to think about, depending on your role, think about the next time you're about to say, well, that's a regulatory requirement. Stop and think, do I really know that for sure? And if not, how can I be certain of it? And secondly, when you're told, well, it's a regulatory requirement, to ask, can you please show me that regulation and where it comes from so that I can understand it better? Sometimes we find that we're limiting ourselves and we think it's in the best interests of our patients and organization, but sometimes it's just not. So be curious, ask questions. Thanks, everyone.
All right, everyone. Thank you for your time today. Again, go to stepsforward.org if you're looking for any further resources from us. Fill out that widget, the survey widget. It'll just take 1 minute, and it helps us understand what you folks are looking for. So thank you very much. You guys have a wonderful day.